According to the American Lung Association, approximately 400,000 Americans are living with lung cancer.
And in 2014, an estimated 225,000 new cases of lung cancer are expected to be diagnosed.
What can we do to either prevent or detect and treat lung cancer early? We'll discuss this topic on this week's Health Talk. We're up next.
Hello, I'm Dr. Vicki Smitak.
And I'm Dr. Eric Mazur. Today we're going to discuss lung cancer with Dr. Stephen Winter, who's a pulmonologist, head of the Norwalk Hospital ICU, and Dr. Sean Tittle, minimally invasive thoracic surgeon.
Welcome to the show, both of you.
Regular guests.
Yes.
Welcome back again and again.
But we're talking about a fairly serious topic, lung cancer,
yes.
and the numbers are quite staggering. I would say that everybody thinks of other cancers maybe before they think of lung cancer as being a leading killer. But Sean, I think you've told us otherwise when we were preparing for the show backstage.
Yeah, there are a number of fallacies out there, I think, that the lay public believes. One is that, for example, women, I think of breast cancer as the number one killer. Please dissuade them from that.
Well, lung cancer is the number one killer of women, but if you look at the polls of women, perceptually, only 1% of women even identify lung cancer as a cancer killer in women. About 80% of people think it's breast cancer. Breast cancer is very common, but far more women die from lung cancer, and it's a very
Because lung cancer is so much more lethal.
Yes.
And that's a disconnect, I think, Sean, right? Because breast cancer, like you said, is so much more common, and so we see that on the forefront, and we think, well, cancer, it's bad, maybe you die from it, but we don't really stop to think that there are other cancers like lung cancer, and not only in smokers, Steve.
That's right. But it's even more striking than that suggests. If you take all the people, all the men and women who die of breast, colon, and prostate cancer, the three big ones that we think of, that number is less than the number of men and women who die of lung cancer. So it's a major health problem, and one that has really been transformed over the past decade. We have so many exciting new developments.
And I think that there is a perception out there that lung cancer occurs only in smokers, and therefore people bring it on themselves, and if I don't smoke, I don't have to worry at all about that. And we know that's not true either.
That's really awful. The Lung Cancer Project did a survey, and they found that 3 out of 4 people had a negative view of lung cancer patients. That there was shame, that there was hopelessness, that they had done something to bring that upon themselves. And that's really awful. If we treated breast cancer patients like that, rightfully so, there'd be a lot of people standing up and saying this isn't right. And it's just a shame that we're not treating it the same way. The second part is the number 7 leading cancer killer in the world is lung cancer in people who never smoked.
So we're not telling people that it's okay
shocking.
to smoke, though, are we?
Right.
No, but
Right.
15%
Right.
of patients were never smokers who come in with lung cancer.
And that's really frightening. Why does that happen? I mean, I know that that's probably the big black box question, but
Right.
in smokers you can sort of see a causality. You smoke X number of pack years or cigarettes per year, and you know that you stand a greater chance of developing lung cancer. But why are we seeing a rise in patients who've never smoked before?
Yeah. I have to say, first of all, that nearly 90% of patients who develop cancer were smokers. But in women who develop cancer, and it's particularly true in women, 15% have never smoked or smoked very little. And it seems that the vast majority of those cancers that we see in this non-smoking group have specific kinds of mutations that we've seen in the genetic material. And it's quite common in women, non-smokers, and particularly of Asian origin, particularly Japan and China. And we don't understand why this is occurring, but it's been a striking change in the face of lung cancer in the past decade or 20 years.
Now, what role does secondhand smoke exposure play? Would we say women non-smokers or anybody smoker versus non-smoker, we're not factoring in exposure to secondhand smoke, or are we?
You know, we consider that, and there are other things, asbestos exposure to radon in the home environment, secondhand smoke, all contribute to the risk of lung cancer. But when you put all of those aside and take very, very careful histories to exclude those as being important parts of the background of a particular patient with cancer, we're still seeing a surprising number of patients who have cancers. 15% in women, as I said, about 5% of men with lung cancer have never smoked. We don't understand yet.
We're beginning to even see changes in the kind of lung cancer that's presenting over time, are we not? I mean, I remember when early on, this form called epidermoid lung cancer was the most dominant, and we're seeing different histologies evolve over time.
We are seeing shifts, and some of the shift too is that with our new strategies of, for example, lung cancer screening, which we started at Norwalk about 3 years ago, we're seeing much earlier cancers being found, diagnosed, and treated, and cured. There are just striking changes that are occurring in the way we diagnose lung cancer, the way we determine whether or not it's spread. The surgical techniques are profoundly different. And the understanding of the genetic profile that helps lead us to very new and exciting therapies.
So maybe we could start, with and sort of march through all the new things with lung cancer. First of all, prevention. I think we all know that don't smoke if you've never smoked. Stop smoking if you do smoke.
Right.
That's the biggest, I guess, impact we could have in our society. Beyond that, I know there have also been some studies about certain vitamin supplementation and things. Is there anything else people can do to prevent lung cancer?
Well, the vitamin studies have been actually not only negative,
Right.
the opposite of negative, that patients taking extra of these antioxidant vitamins were more likely to get lung cancer. So,
wow.
You should probably say that again, because I think a lot of people out there with the Madison Avenue has convinced everybody that antioxidants are good no
Right.
matter what. And there were these very carefully controlled studies done with, I think, vitamin E and lung cancer.
Vitamin E and vitamin A both were shown to have a negative effect, but it was in the pills that you take, the synthetic vitamin E and A, and there is some suggestion in the data that if you have it through natural foods and the mix of things that occur in real food, that there may be real benefits. So it's very much uncertain at this point.
Do we ever see lung cancers run in families? I'm sorry, Vicki. Sean, go ahead.
I think that what we'll end up finding as we learn more about the DNA mutations in these diseases, there are a limited number of DNA mutations, and it shows up as different cancers in different people. And there's a propensity, I think, in a family where you have all red hair, that you may have a particular genetic change also, or people who have a certain skin tone, complexion color, or things like that, that run in families. I think we'll find out there will be DNA mutations that we can target eventually, hopefully, and treat these people much earlier and much more proactively.
But again, going back to what you said earlier, Steve, you said that by and large, the majority of lung cancer you can link to some exposure to cigarette smoke. So when, Eric, you ask about prevention, I always think the best way to prevent lung cancer is by not smoking, right? So that thinking hasn't really changed tremendously.
Not at all. It's the single greatest reversible health risk, and it's not just, smoking doesn't just cause lung cancer, it causes gastric cancer, mouth cancer, it contributes to stroke and heart disease. It is bad on every level that you can imagine. If your kids smoke, make them not smoke. Find a way to convince them. It's the most lethal product available in the market as legal. It's really extraordinary.
And there's been so much education about, obviously over the decades now that we know what smoking can do, not just as far as lung cancer, but everything else, like you said, to the extent where smoking is really seen as a taboo sort of activity these days, at least in our neck of the woods, it certainly is. I don't know statistically what the rates of adolescent smoking is in our community versus others. I know that it's lower than it used to be. I don't have exact numbers, but we have seen trends in that direction, right, Sean, that we're not seeing young adults or adolescents picking up smoking as routinely as they might have used to, but it's still happening.
Yes.
And so the education has to continue.
Rates have fallen quite a bit, and one of the concerns is the new thing, vaping, that is the electronic cigarettes that vaporize nicotine. It doesn't have the same kind of lung cancer risk, although it does have cardiovascular consequences. And it's really clearly associated with starting smoking as well. It's a point of entry. It's not a complete replacement for smoking.
Yeah.
And it's actually a nicotine delivery system.
Exactly.
A very effective nicotine delivery system.
Yeah.
So
Can I just add one thing
please.
to that real quick, just because this is a real point of interest for me. Smoking isn't necessarily socially acceptable as much as it was. This isn't the 1960s.
Right.
But we have to separate the disease from the habit that we find irritating when we go into a restaurant. We shouldn't look down on people who have lung cancer just because they smoked in the past. They didn't.
Absolutely.
They don't deserve it.
Yeah.
Just like, you don't deserve a stroke if you eat a normal American diet and you like to have Doritos. It doesn't mean you deserve to have a stroke.
Right.
There are some things that you can do to change, but the people with this disease deserve all
I
of
think
the
that's an
research
important-
funding and
Absolutely.
compassion and care and treatment and loss of the stigma that they have.
And I think that's
because they
a
have
really
this
important
disease.
That is
point because
important.
I think as we look around, particularly with research funding, sympathetic causes, children, and I don't mean in any way to,
Yeah.
but children
Yeah.
are easy to fund,
Right.
women, breast cancer, et cetera. But then there
It's
are
over
these,
5 times the amount of funding per death for breast cancer than it is for lung cancer. And I understand that that's a much more appealing project and it doesn't have the negative stigma, but we really need to, we have to separate our personal feelings from taking care of people with a disease. And the disease is cancer.
Yeah.
And their cancer is in their lungs.
and these are the tragedy every bit as much as breast cancer or any other kind of cancer that threatens someone's life.
No, that's a really good point to make, and I hope that our viewers out there are getting that message. That it shouldn't be stigmatizing. We should be providing the same care and the same funding for the care.
So Steve has said, you've both said, that the whole world of lung cancer has been turned on its head, and still we've basically given the same message we were giving back in the 1970s, which is stop smoking. But there have been new advances all along the way. So let's talk a little bit about screening. That in the old days, up until very recently, there wasn't thought to be any effective screening method to reduce the mortality from breast cancer. That's changed completely, hasn't it?
Yeah, screening is important that you identify the high-risk patients, and what is considered high risk now by the current standards are having smoked a pack a day for 30 years or 2 packs a day for 15 years, some combination that adds up to 30 pack years, being between the age of 55 and 75, and having smoked within the past 15 years. Those are what we've categorized with the most recent trials as high risk. And we know that if we do annual screening of those high-risk groups, you can reduce the likelihood of dying of lung cancer by 20%. Lung cancer screening is far more effective than mammography, colonoscopy for colon cancer, or prostate-specific antigen for
When you say more
prostate cancer.
effective, is that the cost per death, the cost of screening the high-risk population per death that you prevent? Is that
Based on the cost per death and the number of patients you have to screen to save a life is lower with lung cancer screening than any of the other screening modalities.
And I'm going to
Yeah.
close out of this segment right now, but I'd like when we come back to talk a little bit more about screening and what it is, what the trials are, and then move on through the rest of lung cancer so we can talk about how it's been turned on its head. So I want to thank Steve and Sean, and we'll be back after this short break.
Yeah. Salad on Saturday, fruit on Friday, throw a ball Thursday.
Water Wednesday, touch your toes Tuesday. Let's move Monday, spark a snack Sunday.
60 minutes of physical activity a day and eating well can help get your child healthy. So keep them active and eating well every day. Get ideas, get involved, get going at letsmove.gov. That's letsmove.gov.
Oh, those boys are much too much. Those boys are much too much. We got the spirit. We're hot. We can't be stopped. We got the spirit. We're hot. We can't be stopped. We're gonna beat them and bust them. Beat them.
The smallest moments can have the biggest impact on a child's life.
Let's get a little bit rowdy. R-O-W-D-Y.
Take time to be a
One
dad
more time.
today.
Oh, those boys are much too much. Those boys.
Bring out the action hero in you. Fuel up right and get energized. Be part of the greatest action movie ever. The first movie that puts you in the action. Show us how you train and eat like an action hero. Join in at actionheroalliance.com.
The first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
Hi, we're back with Dr. Steve Winter and Dr. Sean Tittle talking about lung cancer. We were just getting into the issue of screening.
So we have a program that is pretty unique, although more programs are now available across the country, but we have one of the first programs in the country and in the Northeast. Tell us a little bit about our screening program for lung cancer.
Well, we have the first screening program in Connecticut. We initially did it at the cost for us to do the screening. We realized it was so powerful and making such a difference. As we found we replicated the national study, that we made it free last year to really encourage people who are at risk to be screened.
And this is through CAT scan, Sean.
It is. And some people may not find it that appealing to have a CAT scan. Some people bring up the idea of having extra radiation exposure. But in reality, if your risk hits that threshold of the 30-pack year, your risk of having a CT scan every year for the rest of your life is far outweighed by your risk of developing lung cancer. And when we say these sort of sterile numbers, 20%, there's no way to give a statistic with life, but if you have 5 family members and you could save one of their lives,
Right.
for sure, by doing screening, that would be very impactful if you were describing mammograms or colonoscopies that way.
Right.
And lung
It's
cancer,
part of that negative thought about lung cancer that kind of keeps people from getting screened.
but without screening, lung cancer typically presents late. It used to be, what I remembered was 5 or 10% of people would be curable and be detected early enough, and the rest were destined to have metastatic disease and die. By those 20% you're catching, these are people that would otherwise have died that you're catching early.
And the whole point is to pick the cancer up when it's very, very tiny, so
That's
that
right.
you can
Yeah.
go in and resect it. Sean, as a thoracic surgeon, this is what you do, among
It's
other
better to
things.
take out something small than something big.
Absolutely. And something that hasn't spread elsewhere, right?
Well, the
you're
bigger a
talking about
tumor
it-
is, the more likely it's spread, the longer it's been there,
Right.
and it can grow into local organs as well as spread to distant organs.
Right.
And it's really a different sort of shift in the way we treat from a surgical standpoint, because one of the things that I have in mind, if I'm ever treating somebody who was found on a screen and we're doing an operation, I'm pretty much assuming they're going to live through this and they may develop a second issue that we'll have to deal with in the future. That's good and bad because your risk never completely goes to zero, but it's good if you would have died from that disease 20 years ago and instead you have good quality of life and you could go back and live your life normally in the future.
Now, again, we don't have a lot of time, but I want to get through all the changes. Minimally invasive has really taken over the world of lung cancer, both in terms of staging them, evaluating the extent of the disease, and I know, Steve, you do a particular procedure that allows us to look at this, and as well as a treatment. Sean, we had you on a few shows ago, I think, where you brought the old rib spreaders, and we talked about how painful and significant surgery used to be, and now you can do it through the robots. So tell us then through the
Well, I always sell minimally invasive surgery, so I'd rather have Steve talk about it if he wouldn't mind, because he gets to see the patients from a different view that's not as biased as looking at it from a surgery standpoint.
And for me, seeing a patient the day after getting minimally invasive robot-assisted surgery is a world apart from the past. In the past, patients would have their chest opened up. They'd have tremendous pain. Even the first couple of days after surgery, they'd be on a lot of pain medications and terribly uncomfortable, and you kind of dreaded walking into the room. Now to see a patient day one post-operatively, They typically are sitting in bed reading the New York Times. They're relaxed. They're taking maybe one pain pill every 6 hours or 8 hours. It's a world of difference. And I think the new procedures, the new approaches with minimal invasion, or using the robot to make the movements and the trauma to the local tissue just tiny, has transformed the recovery. So you're not saving more lives with minimally invasive, but the way
You're
you feel
reducing
and
the
how
morbidity.
quickly you're back to work. I mean, I routinely see patients going back to work in a week after a major lung surgery. It used to be 3 to 6 months. That is transformation.
Wow. What is the gender distribution that you see in the screening program? So folks who are coming to you or to radiology and getting a CT scan, are we seeing, is it really heavily weighted male versus female? Are you seeing a lot of women coming forth for screening? Just curious about that breakdown.
Just ballpark in my mind, it feels pretty symmetrical, pretty equal.
Is that right?
And I think I see more women who go to surgery who are having early cancers found. That's my own experience, but
Yeah.
I'm not sure if it's reflected more broadly.
Yeah.
I've seen the same thing, and I've attributed it in my head to women generally being more proactive about their health issues.
Yeah.
I was
Yeah.
just going to
Yeah.
suggest
I agree.
that
That
more men
we
are out
men
there,
are
but
not
they're not
particularly
coming
good
in.
at caring for ourselves.
Right.
No,
Yeah.
no.
And I think we male doctors are probably as bad as the average we men out there.
Yes,
Probably
I'm
worse.
sure.
Maybe worse.
But I think it's disproportionately high female compared to risk overall.
That's what I was
But
thinking.
we've seen more early stage, anecdotally, we've seen more early stage disease that we took out of women, and they have just done really, really well.
And so just to
That's
make the
remarkable.
point, sometimes a lot of people, and for the longest time, people thought more was better. The old Halsted radical mastectomy, the more surgery you did, the more bloody it was, the more you could get at every bit of the cancer. Just reassure people, if you would, that this minimally invasive technique is just every bit as good as the old-fashioned surgery.
Well, yeah, it may actually be better. There's more data coming out. There's data that came out last month that showed that minimally invasive surgery probably has not only improved complication rates, but improved survival, because you have a better grasp of finding out whether the tumor spread at all.
And certainly, if you can get into areas and see them better using the minimally invasive tools than you can sort of staring into a large wound.
If I had a choice of being bitten between a shark and a minnow, I think I'd pick the minnow myself.
Nice way to put it.
You can show off a big scar, but if it takes you
Yeah.
6 months to go back to the things you love to do, that's not great.
Are there certain types of patients that do better versus other types of patients that are picked up at the same sort of stage?
Women do better across the board.
Yeah. And we just
People-
have a minute or so
Yes.
left, but it's also been a big change in our understanding of lung cancer, genetic profiling. Maybe you could say something about that, Steve.
Yeah, we're finding that there are mutations in the cancer tissue itself that really define how the cancer has developed and how it spreads and progresses. And there are new targeted therapies that actually block the biochemical pathways that allow the cancer to progress. We're at a very exciting time. About 50% of lung cancers now are associated with a particular known genetic mutation. I would guess in a few years it'll be 100%. And once we know the mutation, we can target therapies very specifically with medicines that are not very toxic and are very, very effective. It's a really exciting time in cancer and the way we treat and think about it.
This is the genetic revolution that people were hoping for 20 years ago,
It's
that we're
happening.
finally beginning to see
Yeah.
right now. Because I know that we talked about this early in my career, and yet we really didn't see products that were taking advantage of this,
Right.
and this has changed everything for us.
Right, so we have surgery, we have medical options. There's really, like you said, a big revolution in the treatment of
And
lung
we can
cancer.
screen it early. Thank you. This has been a really,
Yeah.
I think, illuminating topic for people at home, because this area has changed so dramatically.
Absolutely.
So we're going to ask Steve to join us to help answer the question. When we come back, we will have today's health question.
Right now, let's take a look at some of our upcoming events sponsored by Norwalk Hospital.
first 30 seconds are all I remember. My doctor told me I had cancer. When the shock was over, I met with a cancer specialist at Norwalk Hospital. We weighed all my options: surgery, radiation therapy, chemotherapy, even the latest clinical trials. Their Whittingham Cancer Centre offered me personalised care, hope and leading cancer physicians. And I know great care. Besides being a cancer survivor, I'm also an ICU nurse, and I chose Norwalk Hospital.
Nice. No! Oops. Yeah, sure. Let's go.
Moms everywhere are finding ways to keep kids active and healthy.
Works every time.
Get ideas, get involved, get going at letsmove.gov.
Mom, can I have $1?
Yeah, it's right. I think my purse is upstairs on the bed.
It's not here.
Check the dining room.
No.
What about your sister's room?
It's not there either.
The upstairs closet? The downstairs closet?
There are no more closets.
Moms everywhere are finding ways to keep kids active and healthy. Get ideas, get involved, get going at letsmove.gov.
This week's viewer question is, what is chronic obstructive pulmonary disease, or COPD?
COPD.
And we have some experts here to help us answer
Right, I
this
don't have to
question.
answer
In
that question. Go
particular,
ahead,
Dr.
Steve. What is
Winter.
COPD?
In reality, COPD spans a spectrum of diseases that include chronic bronchitis, emphysema, bronchiectasis, which is a variant of that theme, and even asthma. And it's really a misnaming. There's nothing obstructive about COPD. It's really either a floppiness of the airways, that they don't stay open, or swelling and inflammation of the airways that make them narrow. And it's really a restriction on how easily the air gets out of the lungs. And so COPD in general is this spectrum of disease, and it can be caused by cigarette smoking, by exposure to toxic dusts, by exposure to toxic chemicals like chlorine, and it's not just about smoking.
Now, Sean, I know that it used to be that patients' pulmonary status, we had to look at that very closely before they ever had thoracic surgery, because you couldn't do major surgery on somebody with bad lungs. Have the minimally invasive techniques allowed you to operate on people with more severe COPD than in the past?
Absolutely, and safely, because that's the point. You can operate on anyone, but if your risk is very high, I tell the patients, I didn't come to work to bump anybody off today, so expanding the criteria under which we can offer someone potentially life-saving care is very important.
And the same patients who get COPD are the same patients who are at risk for lung cancer, in most instances, I'd say.
Absolutely.
COPD versus asthma, Steve, just real quick in the few seconds we have left, any sort of, I mean, they sort of fit into that same bucket, but these are different disease
They're quite
processes.
different, and asthma, the airways are narrow, they're often inflamed, and so passage of air through the airways is restricted by that, that narrowing, where with COPD, it's usually the airways don't remain open, that the structure that holds them open has been damaged, usually
So
by
I
smoking.
hope that everybody understands now what COPD is, and understand that lung cancer has changed. So if you at home have a question you'd like to ask on Health Talk, please contact Vicki and me at healthtalk@norwalkhealth.org.
Eric and I would like to thank our guests today, Dr. Stephen Winter and Dr. Sean Tittle, and we'll see you next week on Health Talk. Stay well.
Bye-bye.